Hi, I'm Dr. Manimala Selvinaika. I'm a histopathologist and statistician, and this is an EBM video about causation or causality. Now, a disclaimer first. Now, as usual, to the rest of medicine, this area has got lots of terminology confusion in the medical literature. And number two, I'm not a lawyer. So the way I interpret court cases is how a doctor would interpret court cases, right? So appreciate input by the legal fraternity. Now, when we want to look at causation, we have to break it up and be clear about at what level we are looking at causation, right? You can have causation in a population. Look for causation in a population. This is a quantitative numerical method, right? Then you can have to look for causation of something in an individual. This is a qualitative method. It's non-numerical. Then you have got the problem of looking for causation in a living person, and you can also look for causation in a dead person. Now, for causation, that means did drug A cause adverse reaction B? I'm going to use the WHO definition and I'll clarify some of it according to my understanding. So if you think that is not correct, you can let me know. Now, the most important thing when it comes to classification of adverse outcomes is temporality. That means drug A must be given first, then only adverse reaction B must occur. It cannot be done the other way around. So temporality is a non-negotiable criteria, right? So the easiest way to think of it is to think of adverse event as a big go down, right? So the moment you give the drug, anything medical that happens after that must be entered into the go down, right? It may or may not be causally related to the drug you just gave, but you just put it there first. Then later on, people will examine it in a systematic way. For example, if after you gave drug A, someone falls from the stairs, they could have fallen down because they were not wearing their glasses, but it could also be a side effect of the drug or an adverse reaction of the drug. At this point, we don't know. Park it in the go down. Somebody will look at it. Now, once these cases have accumulated, somebody will look at it to decide whether or not it's an adverse reaction. So adverse reaction is something that is temporarily related to the drug. Okay, that means that it came after the drug was given, but it has got adverse effect, that means noxious effect, that means unwanted and unintended. And it must be in normal doses. Now, if you give someone a very high dose of drug and they develop some reactions, that is not considered an adverse reaction, right? That is poisoning. And it must be at least plausibly causally related. There must be some evidence to show that it could or possibly be related to the drug. Right? Now you've got expected adverse reaction and unexpected adverse reaction. Now side effect is a little bit different because it is related to the drug. Okay, it's an unintended consequence at normal doses, but it can also be something that can be beneficial to some people. For example, if you give antihypertensive drug, it can also, let's say it causes hair growth. Now, to most people, they would not want it, but to someone who is bald, they may be quite happy to take that antihypertensive drug, right? So, a side effect is a little bit different from adverse reaction. Again, there's terminology confusion. So, if you have got a more authoritative definition, then please let me know. Now, signal. Now, with all this vaccination, everyone is talking about signal, right? A signal is when you suspect that the drug has got some causal relationship with the adverse reaction that you are thinking of. And it must be an adverse reaction that is not known or well documented for this particular drug. And usually more than one report is needed, and it also depends on the quality of the reporting and the seriousness of the event and all that. But understanding a signal is quite important, right? Because if you don't pick up on signals, you will miss that adverse reaction until many people have suffered from it, and that's not a very good thing. Now, when you talk of adverse event or adverse reaction, they can be classified as mild, moderate, severe, and serious. Now, sometimes people interchange severe and serious. Serious is different from severe, right? It's something that can cause death or is life-threatening, right? So there are two different things, but I've seen people using it interchangeably. So you need to be careful about it. Now, this is the interesting part. Frequency of adverse events. So we label frequency of events as very common if it's 10% or higher, common if it's between 1 and 10%, uncommon if it's between 0.1 and 1%, rare if it's between 0.01 and 0.1%, and very rare if it's less than 0.01%, right? So I've given you the numerical and the percentages there. Next comes certainty. How certain are you that this particular adverse event is actually an adverse reaction related to the drug in question? Number one, the time. The drug must be given first and then only the adverse event must occur. And there must be an event or a lab test abnormality. Now, to be certain, there must be no other disease or drug being taken that can cause the adverse event. And when you withdraw the drug, there should be some cessation of the event. And when you re-give the drug again, the event must recur, right? And it must be a definitive event, not something that is hard to pin down. So now this challenge, withdrawing the drug and re-challenging with the drug, obviously you can't do it in a dead person, right? So if you look at the criteria for certainty, you will find that not everything can be used in a dead person, and even in a live person you may not want to re-challenge them if the adverse event was severe enough. You know, that would be quite irresponsible and unethical. So when you want to ascertain causality, there are certain limitations as to what you can do. So your sense of what shall I say, your antenna has to be very alert for to look for these adverse events. Now, when it comes to the next grade is probable. Again, it's very unlikely that the adverse event was caused by another disease or some other drug, and when you stop the drug, it seems to go away. So that's probable. Then the next level is possible, and then it's unlikely, whereby yeah, it did develop after the drug was given, but the time frame is not, you know, it's either too early or too late, and the person has other diseases or is taking other drugs which can also explain it. Then you have got things like conditional or unaccessible. You know, these are things that you keep on standby. You have to review it at a later date when more information becomes available. Now, this is my favorite slide. Okay, now this is known as the Bradford-Hill criteria, and it basically answers the question, did drug A cause B? So now here, since we're all talking about vaccine, so the question is, did vaccine A cause adverse reaction B? Now, the thing about Sir Bradford-Hill that people got to understand is he's a medical statistician, but he used to be a fighter pilot, right? So when he put up this criteria, he's not a doctor, he's a Navy fighter pilot. I feel that he put it in such a way that he didn't specify what can be used in population and what cannot be used in an individual, right? Now, temporality is a criteria, whether it's in the population or individual, that is non-negotiable, it has to come first. Now, strength of association is not something that you can tell a patient in front of you. A patient in front of you comes and complains of an adverse event. You can't tell him, oh, you don't have strength of association, because that is a numerical thing. That is something that you look in the population. You can't use it to decide for this particular patient in front of you unless it has already been established in the population, right? Likewise, specificity, consistency, RCT, all these are population level markers of causality. Now, when you have a patient sitting in front of you and says, you know, doctor, I took this drug and then now I've got this reaction, is it due to the drug, right? What you can rely on is, of course, temporality. Now, if it's already well established, then you can say, yes, this reaction is known to be known to occur in for this drug in the population already. But if it's not known, it's a very brand new drug, then you've got to rely on other criteria like coherence. That means, does the story fit, right? Is it a patient who was very well prior and nothing and then now suddenly developed? Is there biological plausibility, right? And biological gradient, that is your dose response gradient. Analogy, that means that you know, this kind of effect also occurs in another similar drug, right? And reversibility, that means if I stop the drug, does the reaction stop, and if I give the drug, does the reaction restart again? So some of these criteria can only be used numerically at a population level, and only some criteria can be used to determine causation at an individual patient level. So I think this has to be clearly understood. Okay, now the problem that we face is, the way I see it, is a lot of doctors don't understand what a regulatory approval means, right? Now, the RCTs or whatever studies done by pharmaceutical companies, don't forget these are just businessmen, for regulatory approval are typically not comprehensive. Surprising as it may be, these are not comprehensive studies. Why? One, the duration of the study is very short, right? Usually a few months. Why? Because most of these novel drugs have got shelf life for the patent is usually about 20 years. So if they spend the first 5 years developing the drug, testing in animals and things like that, they can't do what shall I say, follow up for 3 years or 4 years. They typically will do it for a few months or maybe a year, because they need the rest of the patent period to be able to recoup their what shall I say, investment, and these typically run into hundreds of millions of dollars. So it's understood that pharma studies are usually studies meant for regulatory approval are usually short duration, so we don't know the long-term effect of these drugs. Number two, power of the study. Now usually something done by the pharmaceutical companies is small. The sample size is usually smaller than what typically that you would give in a post phase 4 or post-marketing population. So a lot of rare side effects will not be picked up in a pharma study, for a regulatory study, because the power of the study is too low, right? So you must understand that the approval given by a regulatory body is a marketing approval for on-label advertisement purposes, right? In a way, it's easier to think of regulatory bodies as consumer protection agencies, whereby they just tell you that, you know, yeah, this businessman wants to sell this drug. He's claiming that it is safe. Yeah, it is safe in the short term. And he's saying that it's efficacious. Yeah, it does show some efficacy. So it means that the claim is not a lie. Okay. Number two, you got to remember that the drug testing is not done by the regulatory agency. It is done by the businessman, and the results shown to the regulatory agency. So there is no absolute guarantee that the results being shown to the regulatory agencies are complete or even real. Now, recently we had an article in the British Medical Journal claiming that there was some data falsification in one of the drug manufacturers, right? Now, just because a regulatory agency approves a drug, it doesn't mean they are recommending the drug to anybody. It's a new drug, okay? So there's no recommendation. They are just saying, well, we have approved it based on the short duration of study and the small sample size. That's it. They're not recommending it to anybody. And the safety profile of a drug usually, I mean, this is something that they teach at a very basic, it's very basic. They are taught in medical school. The safety profile of a drug will take at least 20 years of continuous and substantial use before it becomes clear. Why? Because when you market the drug, then a larger number of people than who are in the clinical trial will take the drug. So you will pick up any rare side effect. Number two, some adverse effects take time to develop, right? They will develop a few years after you have taken the drug, or if you're taking the drug continuously, then that also will take some time. Or if the drug was given to a pregnant lady, the baby might be born okay, but after a few years may develop some adverse reaction. So usually it's about 20 years. So if someone comes and asks me about a new drug, is it safe? I'll say I don't know, because we haven't had enough time to study its safety profile. Right. Now, what is the problem with studying adverse reactions? Right. Now, let me give you an example. Now, suppose if I give you drug A and someone turns green, we will have no doubt that this person turned green because of drug A, even if the person has previous heart condition or hypertension or diabetes. We will cut through all that and say, no, he turned green because of the drug. Why? Because turning green is not a natural phenomenon that occurs in human beings. We don't have a baseline level of green people around. Okay, so if the magnitude is either great in terms of quality or quantity, we will have no difficulty in picking up and identifying it as an adverse reaction. But if the magnitude is smaller, of the adverse reaction is smaller in terms of quality or quantity, then we are going to have difficulty in picking it up, which is what happened to after the mRNA vaccine. Picking up myocarditis was a very controversial issue. The media was saying no, there's a baseline rate of myocarditis, and even to pick up the thrombotic events in the vector vaccines also, people were saying things like, oh, you get DVT after OCP and all that. So because these were rare events, it is very difficult to pin it down and say it is due to the vaccine. But of course now it's becoming clearer that it is due to the vaccine, at least in some cases. Now, part of the problem is due to the fact that we have to know the background rate. If we take mRNA vaccine and myocarditis, we have to know the background rate of myocarditis, right? Now, most of these things we would have never studied the background rate. We don't know, because the background rate in old people may be different, in young people different. We have most things in medicine, we don't have data for it. So the problem is we are expected to use an expected rate which the drug regulatory authority tells us. Now, if we do not know the rate and it's not available in the public domain or any domain, how will the drug regulatory authority tell us? So they're basically going to go by whatever information they have, which might not even be accurate, right? So this is a very big problem, that the background rate is an expected rate which is determined by the regulatory authority. So to determine causality in the population, very difficult to decide what the real background rate is. And second, if the background rate also varies, the variation is big. Now, if we know that the background rate is 1 to 2 per 1,000 and it's very steady, then any increase is easy to spot. But if some years it is 2%, some years it's 5%, some years it is 1%, some years it is 10%, then any new changes brought about by the new drug will be difficult to spot if the drug itself doesn't have a very big numerical impact in terms of adverse reaction. That means it is even 1 or 2 people get the adverse reaction, it is a true adverse reaction. But because numerically it is small, it is very difficult to pick up statistically, right? And secondly, there are many adverse reactions which are asymptomatic. You can develop myocarditis, but it may be asymptomatic. That has been well documented. But we do not know whether it has been looked for and documented in the mRNA vaccines or not, right? So the rate will also depend on whether active screening has been done or only passive reporting is being done. So there are many variables. So here I have made a small chart to show the difference, the impact of background rates and the drug adverse event rate. So the easiest to pick up is if the background rate for the let's say it's myocarditis. The background rate of myocarditis is very low and the drug effect rate of myocarditis is very high. So it's very clear. So in any of the other three situations, it's more difficult to pick up. It's there, but you can't pick it up numerically. Okay, so here's an example. Let's say the background rate of myocarditis, natural rate myocarditis is 10 per 10,000 and true myocarditis due to the drug is 1 per 10,000. So that year you will have 11 cases. So what is the difference between 10 and 11 cases? Nothing much. So even though there was one true case of myocarditis induced by the drug, you won't pick it up numerically, right? On the other hand, if the background rate of myocarditis, due to other viruses and all that is 10 per 10,000, but the true myocarditis rate induced by drug A is 100 per 10,000. So this year you are going to have 10 plus 100, that is 110,000, which is very different from the 10 that you get every year, right? So that will be easier to pick up. So numbers matter. Now, so in the absence of background rate, when we do not know background rate, and that's a normal case, we do not know, right? What can we do? So we have to do what this eye surgeon, ophthalmologist in Australia did in 1941. In his clinic, he noticed that there were a lot of babies coming in with congenital cataract, and this was occurring right after an epidemic of German measles, rubella. Now, people found it very difficult to connect rubella to cataract because rubella, the symptoms are very mild. So they couldn't believe that something so mild can have such a profound effect on a child. So, but it was noticed by this ophthalmologist, and what he did was he asked other ophthalmologists, are you seeing an increase in congenital cataract in your practice? And yes, they were seeing. So basically it was a clinical practice determined causality. That means it was not determined by some big shot statistician somewhere or some big research organization. Just a few ophthalmologists around that area, they managed to pass out the causality that said that yes, the German measles is the one or the most likely cause for the congenital cataract, right? So what we should be doing if we want to find out whether myocarditis is prominent or not, or rather is it increasing or not after vaccination, we should be going around asking our cardiologists, hey, are you seeing more people with symptoms of myocarditis? Are you ordering more troponins than or whatever investigations than you normally would, right? So we can't rely on some big research organization or some high-fi statistician to come and do it. You got to do it at the ground level. The cardiologists themselves have to form their own grouping and see whether they are seeing more than they normally would. That is above the baseline. And that is exactly what one cardiologist did in, I think this is US. And this was a very controversial paper when it was published, I think last month. Right? He is a cardiac surgeon and he does nutritional medicine and all that now. And he published a paper saying that the inflammatory markers were increased after vaccination. Now there was, they put an expression of concern and there was a lot of pressure, I think, to remove this paper. But at the end of the day, the data was accurate, right? So when the data is accurate, you can't pull the paper. So what they did, they asked him to correct the typographical errors, and there were some minor things, right? So the paper still stands, and the more important, the percentage of the values of the inflammatory marker is still the same, right? He just rewritten it a little bit. So this is a very good paper because it shows that pre and post there is an objective change. Right. Then the other thing is the type of patient. Now, if you've got a very healthy patient, young healthy patient, no underlying disease, not on any medication, and they develop something after taking a drug, right? So if it is a mild symptom, then you can tell them, you stop the drug and you retake the drug. But if it's a very severe symptom, you can't take that risk. So you have to just classify them as either a certain or a probable case of adverse reaction, right? Now, if a person appears healthy, but when you investigate him further, he has got some underlying disorder or underlying effect. It doesn't automatically mean that the adverse reaction was not due to the drug. You have got to see whether or not that underlying thing has got any bearing on the adverse reaction. Most of us are not exactly the same as the other person. We are all slightly different in height, weight. So, our heart sizes are not exactly the same. Some people have got bicuspid valves, some people have got 3 valves. So, just because a person is different from others doesn't automatically mean that the vaccine or the drug didn't cause the side effect, right? So, this has to be evaluated by an expert panel, not just one person. Now, of course, a person with a pre-existing disease, then it becomes more difficult, and when they become older, it's also more difficult, right? Because their natural expectancy, their natural expectation to remain healthy or alive starts decreasing naturally, right? Now, this is a very interesting case. It is known as the Roger versus Whittaker case. I think it was sometime in the 1990s in Australia. Now here, the judge understood probability theory very well, but unfortunately the surgeon didn't understand it. He didn't tell the patient that the risk of sympathetic ophthalmia was 1 in 14,000 because he thought that was very rare, right? But the judge said no, rare or not, if it's an important adverse event, you must tell the patient. Now this is very important because when a patient is sitting in front of you, yes, you will tell them that the rate of sympathetic ophthalmia is 1 in 14,000. But for you, it's either 0 or 100, meaning you will either get it or not get it. For you as an individual, it is not 1 in 14,000, right? If I give you this drug, you'll either get it or you won't get it. So it's 0 or 100%. So that is something that doctors must understand. You can tell the patient that in the population, sympathetic ophthalmia is 1 in 14,000. But for you, you'll either get it or you won't get it. So it's 0 or 100%, right? Now, where does all these problems about, online people claiming that, accusing that family member died of vaccine injury and all that, where does this problem come about? I suspect it comes about because there is a lack of understanding among the medical fraternity that people do not like to be killed by what they see as something beneficial, right? Most people see vaccines as something beneficial. So if they die after taking it, they're going to be very unhappy about it. They're supposed to live after taking it, not die after taking it. So where does this problem come from? Let me read from this Australian guideline, right? Queensland Health Guideline. Where the doctor is comfortable the death is from a natural cause unrelated to the COVID-19 vaccine, the doctor is encouraged to issue a cause of death certificate. That does not need to be discussed with or reported to the coroner. Okay, now this is where the problem arises. You are asking one single doctor who may or may not have sufficient, expertise in determining causality to decide whether this patient died of COVID-19 vaccine or not. And especially when there is a compensation involved, this is going to cause a lot of unhappiness, right? So, to me, if a person dies within a certain number of days of getting a vaccine, it must be, there must be an inquest, right? There must be an autopsy, there must be an inquest. Why? Because we know that there is a discrepancy between what the clinical diagnosis is and what the diagnosis after autopsy is. Yes, with better tests, better imaging and all, with time that discrepancy has narrowed. But that discrepancy still exists. It's not 100% that your clinical diagnosis and your autopsy diagnosis match. So you would still need that for within a certain time period. If people die after a vaccine, they need to have an autopsy done. Unless the family is willing to say, no, this person was quite ill, so they don't want it. Now, the other problem is people misunderstanding the death certificate, right? Now, in a death certificate, there are 3 important things that you must look for. One is the manner of death. Is it a natural death, accident, suicide, homicide, or undetermined? Most countries, I notice, have got a variation. This doesn't vary very much, right? The second is the cause of death, right? you can break it up into proximate, intervening, contributing, or immediate cause of death. But that is what started the chain of events, right? A person may die of sepsis, but if the one which started the chain of events is a stab wound, then the cause of death is stab wound. It is not sepsis. Now, then comes the mechanism of death, and sometimes people put immediate category of cause of death as mechanism of death, right? Is the final common pathway. This is not etiologically specific. You can die of hemorrhage for various types of cause of death. Cardiac arrhythmia, cardiac arrest, sepsis, asphyxiation. All these are mechanism of death. I have seen, well, at least the media reporting post-vaccine death as spontaneous bronchospasm. Now, as far as I know, something like that would be mechanism of death, not cause of death, right? If we do not know the cause of death, then you have to determine that, that the cause of death is unknown and leave it open. So I don't know whether the media is reporting it wrongly, or that is what is written in the death certificate. So it's a good idea when you are dealing with a new drug or a device, and if there is compensation involved. Now, nobody is suggesting foul play or anything like that. It would be a good idea for an independent observer at the autopsy or at the meeting where they determine causality. And this independent observer should be appointed by the patient or next of kin, right? Because you want to make sure that every avenue has been explored fully. Okay, thank you very much for listening. And as usual, if I've made any mistakes, please let me know. I will highlight the corrections in my Facebook and YouTube page. Thank you.